So the National Institute for Healthcare Management reports that 5% of the population is responsible for half of healthcare spending. Kaiser shared that 1% of their covered lives are frequent ED users who consume 16% of their ED resources. So frequent users, defined as those with 4 or more visits a year, represent 5% of patients, but 25% of volume. Our super users are 0.5% of patients, but 5% of volume, so 1 per shift. Controlling frequent users addresses ED crowding. If we can safely cut our frequent visitors in half, we reclaim space that is really needed for other patients. And if we don't, our volumes will continue to rise and we'll need new construction and upstaffing to take care of the extra patients, costing us millions of dollars. In 2014, Sean Murphy and Dan Nevin, who's an emergency physician working in Washington State, showed that they could cut frequent visits in half with ED case management. With cost accounting, including staffing case managers and lost revenue from insurance, they demonstrated a multi-million-dollar savings. So who are these patients? There's 4 groups. One is convenience users. These include patients with private insurance that are willing to pay steep copays so they get seen immediately, and these are problems that could easily be handled by primary care or urgent care. The other large cohort are Medicaid patients with no out-of-pocket costs, but without a committed primary care. The biggest category is substance-dependent patients. In fact, the CDC defines prescription narcotic use as an epidemic. So if you want to save thousands of lives a year, you just have to say no. And you definitely don't want to be the last one to prescribe Norco after an opiate-related death when state databases make excessive prescribing so apparent. So many frequent users are medically fragile, with escalating visits due to declining health. The blue line, for instance, exemplifies a patient with metastatic cancer. The red line is someone with exacerbations of CHF or COPD. And the green line shows the steady decline of a patient with dementia. The final category are the psychiatrically fragile. These include psychotic patients who are often homeless, and also those that have refractory problems like schizophrenia. The largest segment, though, are anxiety disorders with unrealistic fears and those with emotionally unstable personality disorder. So now that we've reviewed the prevalence and characteristics of frequent ED users, what can we do about it? I'm going to lay out a 7-step program that, if consistently followed, will reduce frequent visitors in half, adding proof to why the ED should be viewed as the hospital's fiscal control center. The first step is to identify all the frequent users. The data needs to be regularly crunched as new cases are constantly arising. Identifying and organizing frequent users has not been incorporated into EMRs as a native function, even though we see many every single day. Second, and most importantly, what you need to do is set up a flag in your EMR. Now here's an example of the Epic EMR at Edward Hospital. And you can see the flag in the second column in the middle for this back pain patient. And I know to go to the care plan for this patient and find out what I'm supposed to do. So related to that, the third thing we need to do is engage ED case managers to help us control these patients. So we were fortunate at my hospital to have 3 of them, and one's on duty 10 hours every single day. In fact, we've recruited one of them to really focus in on these frequent users, our super users, and come up with care plans. Fourth, you need to come up with a very personalized care plan for the patients. This is simply, a list of problems and solutions. We categorize them, and the more complex the case, the more detailed it needs to be. It can be pretty simple in somebody who's an opiate prescription-dependent patient. Fifth, what we do is we find the individuals that are going to be involved in a care network. Now, there's always the primary care physician who is essentially the chief influencer by creating easy access. But in medically complex patients, you'll see specialists. In psychiatric patients, psychologists or psychiatrists. Even family members, if the patient consents, might be involved in trying to reduce visits. Sixth, the case manager needs to keep the care network members regularly engaged and have dynamic communication after every visit to determine the appropriateness of that visit and also what can be done in the future to prevent future visits. So, this kind of ongoing education and encouragement goes a long way. Now, seventh, you need to really continually refine the system because these patients are kind of dynamic. They're constantly changing. So, in the era of population-based healthcare, these case managers that we have currently are going to have permanent job security. And the other thing that we do at Edward is we kind of automate the process. And I want to show you this. So we basically have a daily EMR feed to a secure server, and that is a way for the case manager to access all the care plans and also to fan out messages to the care network. We can look up reports like this. This is one of all newly listed super users, and you can see the first one on the list had 2 visits in the first 6 months, 16 visits in the second 6 months of the most recent year, making them a super user. This particular person had 9 unremarkable CT scans, weekly prescriptions for opiates until we figured out it was not a major problem. And what we've seen already is favorable results with our program. Just in 2 months, we've had a 10% reduction in frequent users and a 16% reduction in admissions by super users. So the frequent users most often are Medicaid, super users are most often Medicare. That's it. Thank you very much.